presentation is fine. So yeah, and I'll be around. And like I said, I'll be on just kind of in and out, I think, for a little chunk of the time. Okay. All right. Well, I guess we can go ahead and get started. Welcome, viewers, to, I think this is our third OCD Texas Learn at Lunch series. And this time we have our new treasurer-elect of OCD Texas, Andrea Alvarez. I'm so excited about that level up in your participation. And I really look forward to seeing a whole lot more of you. And we really, really have needed more representation in San Antonio. Andrea is super well qualified, has been to multiple BTTI trainings, and is extremely dedicated to treating OCD and helping OCD sufferers. So her enthusiasm is just remarkable and inspiring, and she's just the perfect presenter for today.
Well, thank you.
Yeah. So I'm excited I presented on Act 2. I'm a huge Act fan, and mine was a little bit different. I'm really excited to see your presentation today and learn more about Act for OCD.
Awesome. Thank you, Jenny, for that welcome. And I'm really excited to be in here. So as she said, my name is Andrea Alvarez. I'm a licensed professional counselor and supervisor. I own a group clinical practice called AMA Behavioral Therapy, where with that gives me the leverage to get all my associates and therapists trained in OCD. So that way we can provide continuum care in here in San Antonio. Throughout this presentation, I'm definitely going to be obviously talking about ACT, but how it also works with OCD sufferers along the way. So although the presentation is mainly on ACT, I'm going to continue to draw that parallel as we go through. I do welcome questions along the way, so my co-host will be able to read out those questions to me. You don't have to wait till the end of the presentation. I do prefer more of an interaction, even if it's virtual, throughout the presentation. So please don't be hesitant or shy to ask anything. Okay, so with that, understanding ACT for OCD. Our three main goals today is to understand and identify the 6 processes of ACT, how we're going to incorporate ACT with ERP, and then we're going to talk a little bit about the differences and similarities between traditional CBT therapy and ACT as well. As we all know, possibly that the gold standard for OCD is cognitive behavioral therapy and exposure response prevention therapy, as ERPs for short. And it's a gold standard and something that I was BTTI trained through the International OCD Foundation. But along the way, throughout my practice and working with sufferers of OCD, I've really been able to see a positive response when I started incorporating ACT into OCD, and how the transition of going from onset to termination or graduation has been so much a more pleasant experience with the use of ACT. Okay, so what is ACT? Well, ACT stands for Acceptance and Commitment Therapy. It was developed in the mid-1980s by Dr. Stephen Hayes. And his idea is that our lives are not always happy, and in everyone's life there will be suffering. So let's think about how that goes with someone who suffers from OCD. Most of their compulsions or their intrusive thoughts are all about trying to prevent pain. So when I first present ACT to them and say, well, can we accept that in everyone's life there is some sort of suffering, versus trying to avoid or get rid of that pain? So instead of that, it views these things as inevitable. So right off the bat, it just kind of make them sit back a little bit. I'm like, okay, I understand what you're saying, and I can see how this is a probability. Okay, let's see here. So just a little bit more about ACT. ACT is oriented toward learning to live more in the present with your focus on your goals and values, while making room for difficult internal experiences. So throughout the entire time that I'm working with somebody who is suffering from OCD, we go back, and to keep that motivation of working, well, how has OCD taken you away from what you truly value in life? Sometimes it likes to present itself like, well, you are protecting your family if you do this compulsion, but it's a false protection. It's really actually taking them away from their family versus acting or working toward their values. So we can make room for those different difficult experiences as we continue to move forward. So it teaches people on how to engage with painful thoughts and feelings and how to be more comfortable with them through acceptance and mindfulness. Now, of course, if you've been doing ERPs and you know a lot about ERP, that sounds basically exactly like ERP. When we are in the middle of an exposure, we're not talking about the weather, we're not talking about sports, we're talking about what are you feeling right now and how can we get comfortable with that discomfort and using mindfulness in that. So we'll touch base a little bit more about that as well later. So, how we cope with life and our thoughts can make either suffering worse or better. So, sounds a little bit like cognitive behavioral therapy. What is my view on this event? Is my view intensifying my anxiety, intensifying my fear, making this distress worse? Can I therefore see it from a potential different angle as well? So, how we're coping with these thoughts is going to be extremely important as we work through ACT. Okay, so this is a question I present to my clients. Can you live with the possibility of your greatest fears coming true? Sufferers and non sufferers, anybody would shudder with that question because they're probably thinking about what they value in life and how, if that were taken away or somehow that was changed. So it does take a step back and say, okay, this is a very difficult question to pose, but it's extremely important that we look at it as we work through ACT. All right, so that's that part of ACT. So let's talk about a little bit more here as far as the focus of becoming accepting and basically what can we not change? And we learn to live mindfully in the present. So the way I would think about that is that typically OCD is what if, the doubting. Well, what if this will happen? Will that occur? So much to the point they're not in that present moment. They're not hearing the person next to them talk to them. They're not paying attention to maybe the child trying to get their attention or the pet wanting to be petted because you just got home. So can we accept of that what we cannot change and be more in the present moment? So this decision to live with acceptance and certainty is critical if treatment were to succeed. How much time this takes to be able to work through this is really up to the person that you're working with. Sometimes they could be ready on board with it. Sometimes there'll be a little bit of pushback. But when we go through the 6 processes of ACT, it helps them work through it because we know that acceptance isn't necessarily a decision. It's more of a process in itself. So we can still work them through that process. All right, so here we are with our first goal of today. The 6 processes of ACT. So ACT is acceptance. So the first step is acceptance. Trying to avoid or get rid of pain will only make it worse. So when we're accepting uncertainty, you'll also be accepting the possibility that your feared outcome may come true. So let's look at that. So now they feel like, well, what am I giving up in ACT? If you're telling me that I cannot have control, what am I giving up for it? But then we also look to see what are you gaining by doing this, by accepting that you are not in control. And then we talk a little bit more about values and time and etc. So it goes through the processes. So they feel like, okay, if I can accept this, then I can go ahead and move on through an ERP session because an ERP is allowing that acceptance to become true or to be reinforce it. Okay. So the next step of ACT is diffusion. So diffusion looks a little complicated at times, right? So it's just like, okay, we're detaching the thoughts from the meanings and importance that we give them. So what does that mean? So an intrusive thought comes in. We put value on this intrusive thought of because I've had this thought, it must mean that it's true. Or perhaps I'm a horrible person for having this thought. This thought must have come from somewhere or it's going to happen because I've had this thought. So think about the value that we're putting on our intrusive thoughts. And let's look at to see what diffusion is saying. We must detach that value because they're not accurate reflections of reality. People's perception is reality. So if we have 5 different perceptions on the same event, which one is true? Where do we put the value? So if we can start to diffuse that importance from the thought itself, then we are able to make more we can move through it and make less judgments of those thoughts. Okay. So if we're accepting that uncertainty is a possibility of life, we're now defusing the values we give to our thoughts, then let's look at where our values are instead. So I always love to pose a question: what do you value in life? And how has OCD taken you away from it? So these are three cases that I recently have. The first one I'm working with right now. And actually, I just presented ACT to her this very last session. And so hers is contamination. She does spend hours washing her hands, taking baths, making sure that her clothes are clean. She says that she doesn't even like coming home because her first thought goes to what's dirty, what's not. She lives with two other family members. And so she's not even in that present moment. Her mom finally got to come to visit. She was recently vaccinated. So her mom was finally here after this current year being separated. And she said that she was too afraid to hug her mom due to fear of getting dirty. So when we talked about values and OCD and ACT, she could tell she got very choked up and upset with herself for allowing the intensity to get to this point. And her mom, of course, took notice as well and was worried. The very next case I have here as an example, fear of harming others was the core fear. So I have a 27-year-old male paramedic firefighter. So his life is all about saving people. His life is all about helping people. But his intrusive thought is, what if you stab your girlfriend? What if you break her neck? What if you harm her? So instead of coming home after a 48-hour shift, he would try to find ways to continue to work or go somewhere else because he was too afraid to spend time with her. And actually now they're engaged, so that's great, but that was pretty much that part of it. So he recognized that his values are this OCD was taken away from her. Perfectionism. So I do have a 14-year-old male, really cool kid. He's finally back in school, finally get to socialize, and his perfectionism OCD is constantly asking his friends if he did his assignment right. Did I understand it correctly? Do I know what I'm doing correctly? So much so that his friends would answer the questions, but then get tired after the 10th or 15th time, and they started to separate. So instead of seeing that time as to socialize, OCD was taking him away from it and interrupting that. This is, of course, being out of school for a year. We know that socialization is extremely important. So asking the question, what do you value and how has OCD taken away from it, is an extremely important part of working through ACT. Okay, so now that we know our values, now let's start committing our action toward them. So stop delaying your life and work toward the person that you're choosing to be, that you want to be. Start engaging in previously avoided activities that would have been fulfilling. So engaging in time cooking, he wanted to go back and start cooking with his girlfriend again. And he said he was too afraid to cook because of the knife. Kid wants to go back and like have fun with his friends and not spend 3 hours on a homework assignment that he knew should only take him 20 minutes. And then, of course, doing the activities that they've been staying away from because of OCD. So instead of your fear guiding your decisions, we're going to let your values guide your decisions instead. I want to be with my family. I want to pet my dog again. I want to hug my mom. Great. Let's commit action to that as we work toward these ERP work. So part 5 of the 6 processes, this has got 3 subparts to it. So self as a context. I like to talk about conceptualize self as the person that you're striving to be. And that person that you're striving to be is usually made up of the beliefs and evaluations that we use to define ourselves. What's important to me? Is it my family? Is it career? Is it travel? Is it all the above? And how am I now? So self as a process of ongoing awareness, and where is it that I'm striving to be, and what are those differences? So where I'm at now and how am I working toward that? So that's why we see it as a process of moving toward that conceptualized self. This is where I say it's pretty much more of a journey versus a destination, but every time we put step forward, we're getting closer and closer to that conceptualized self. My favorite part, though, is C, the observer self. And the reason why this is my favorite part is because a lot of people, especially with anxiety, will come with a lot of negative self-talk. I'm not where I should be. I'm stupid for missing that opportunity. I am not valuable, and all this negative self-talk when they're trying to look to try to improve themselves. And I'm like, well, that negative talk actually holds you back and it doesn't launch you forward. So can you observe yourself as an ongoing process without judgment? So if you're telling me that running is important to you, you find a lot of value in it, you want to do a marathon, well, what are you doing now to get you closer to it? Well, I haven't done much. Okay, so what do we need to do to get that process going? It doesn't have to be like, why didn't you? How could you not have? Well, how come? It's more of like, let's just get that movement going in itself. So I kind of see it more like an unbiased reporter, is a good way of kind of looking at it. Okay. So the sixth step of ACT is mindfulness. We've already talked a little bit about mindfulness throughout this presentation. So here is the main gist of it, or the meat of it. So mindfulness is to cope with sensations of anxiety. When we talk about mindfulness outside of ACT, a lot of people think of it as just like meditation or deep breathing, trying to calm down the negative feelings of distress or anxiety. Here, mindfulness and ACT, along with our use of ERP, is we can sit with that moment of distress and acknowledge it. What am I feeling? My heart's beating a little bit faster. Okay, what else is going on? I'm feeling a little shaky. Okay, what else are you feeling? We know that that's our fight or flight system kicking into gear. We can acknowledge it and sit with that sensation and not run from it. So it requires that we acknowledge the urge and we abandon the movement, which is a compulsion, because it's distracting from the present moment. And it's also acknowledging and accepting that whatever is happening in that present moment is exactly as it is, versus trying to change it or manipulate it as we try to move forward. So those are the 6 processes of ACT. Our next goal for today is to talk about, well, now how do we incorporate ACT with ERP? So the goal of treatment when working with ERP is really to accept that your OCD fears the same way you accept living with potential non-OCD disasters. I hear this time and time again. I know this doesn't make sense, but I am fearful of this being dirty over here. I can care less over here. So, all right, so let's think about that. So over here, where you can care less, for your words, you are living with that potential non-disaster. You do have the ability of doing this. We just need to bring it over here where OCD is telling you that you cannot live with it. So this approach of ACT, therapists want to help you change the entire view of everything and then assume that this will make the ERP process easier and more natural to move through. So we definitely need ERP method to be able to do this. So being in the present moment without judgment and without trying to change it, like we said, is also mindfulness. It's an extremely important part of ERPs. So ERP also requires mindfulness skills to resist the powerful urges to do compulsions. Where am I feeling this urge? What is OCD telling me? And being in that moment and just, again, being that reporter. A lot of times people say, well, then I'm just accepting that, anything can happen and I'm losing control. It feels like it's defeat. It's like acceptance is not defeat. It's not giving up. It's not giving in. It's accepting reality. So then that way we can use our skills to move forward and even work through the process of healing. But as long as we get stuck there, we're not moving forward. We're kind of just, what ACT says is that we're more in denial versus acceptance. So I know that word is kind of harsh. I even have a hard time saying it in this presentation, but it's just how it's presented in it is going to be extremely important. But acceptance really is accepting the way things are. Okay. So a really good case example, and it's funny because I told her earlier this week, I'm going to use you in my presentation. She was just like, I'm happy to help. So I have this 43-year-old woman, married, and now she came in with previous treatment of CBT and ERP. She's like, I've done it all. I've read all the books. I've done ERPs and sessions before, and I just don't quite get what I'm told I'm supposed to be getting out of it. So, of course, me being a CBT and ERP trained therapist, I'm like, great, what do I have to offer here? So, but she's like, but I'm ready to work. This OCD is really hit a heavy height point to it. And it's really, I'm ready to do this work. So I'm like, okay. So she told me that she had tried Prozac before and she had, quote, bad experiences with that, which I'm pretty sure we're used to hearing from a lot of our clients. She said that she has gone, like I said, both CBT. However, through her progress, she will have frequent relapses. So she'll have progress and then relapse, progress and relapse. She reported that ERP, quote, didn't quite work for her. And so we asked, well, what is your core fear? She said, my core fear is I'm fearful that harm's going to come to my family. That's it. So taking a step back, trying to look at the entire case, I had two thoughts going at the same time. One is, okay, she hasn't mentioned ACT, although she said she had a book on mindfulness. And I was questioning the core fear. So when I went to question the core fear, she's like, I already told you. I was like, wait a minute, let's work with me here. Let's get down a little bit further. So she's like, okay, what is the worst thing happen? Something happens to my husband. Okay. And then? And then she stopped and paused. She's like, well, it'll be a great deal of pain. Okay. And then I don't think I can handle that pain. Okay. This is our core fear now. Now we understand what's truly going on. Perhaps it's one of the reasons why ERP hasn't quite worked. But now let's take it a step further. Let's look at all the things that you're trying to do to prevent this pain. She's having to repeat daily activities, put her bottle cap on right, put it just right in the fridge, and it will start from the moment she wakes up, having to get the bed made just right, and all these activities that to try to prevent this fear. So when I said, can we live with that possibility? It totally kind of shook her from a different way. So we talked about acceptance and we looked at how can we accept the possibility of this being true. It's what mostly we have to accept in life in general. We try to give ourselves the illusion of control by saying, I'll see you next week. We don't say, well, if nothing happens to you, nothing happens to me, or Snowbit Part 2 happens, then we get to see each other. But in actuality, it's very much the truth. But we still live with our values. We still work toward what we're wanting to accomplish and knowing and acknowledging that fear of the possibility of our fears coming true. So kind of saw the light bulb moment. She's like, okay, I've got this. Now I can do this work. So going back and working through ERP, we took that example of, okay, what is OCD telling you? Must do this just right. If not, harm can happen. ACT, I must accept the possibility and that harm can happen. So what's my value? I want to spend time with my husband. Okay. So can we abandon that compulsion and then look toward how we're going to be in that moment to be with your husband instead of repeating your daily activities over and over again? So she's like, okay, let's do this. So I've been able to see really positive results with that so far. But I think had we had not incorporated ACT, I'm not too sure she would have been able to have even gotten to that point. I think we would have been doing the ERPs again and not having as much success as we previously had. Well, the side note, she was also fighting bringing in her husband. Caught her on that one too. He came in. It was good. All right. Any questions in regards to that case? Okay. All right. So now we're at our last part. ACT versus traditional cognitive behavioral therapy. So let's look at traditional CBT. It's also a theory-driven approach to treatment. It also looks at the appraisal perspective that dominates the CBT research and practice in OCD. So with CBT, we look at, well, what are your possible thinking errors? And then identifying those thinking errors and then working toward reevaluating them to see if there's an alternative way. So trigger, thought, your response to it, how can we challenge that thought and work through like evidence for, evidence against, and then that way we can go ahead and change that appraisal. So a person's subjective evaluation or appraisal of the personal significance of situation, object, or event. So here the focus is what we're thinking versus how we're thinking. So what is the thought itself and how can we look to possibly change or alter it or see it from a different perspective? So the traditional CBT model, a stimulus happens, whether it be like a triggering event, they have the unwanted mental intrusion, they have a faulty appraisal belief. That's that what we talked about, that value. They then try to neutralize it with compulsions to bring it down. As that happens, their anxiety goes down and their perceived control goes up. Well, this works, right? Because my anxiety is less, my distress is less, so therefore this must be true. So because of that, now your thoughts are kind of like, okay, I'm kind of having it more awareness. So anytime that thought comes anywhere in the side view mirror, it's going to trigger this process yet again and go into that outline of the cognitive behavioral part of CBT. Okay. So
I,
cognitive, go ahead.
yeah. So with your the model that you presented, yes, here, and then if we think about ACT, would under an ACT kind of conceptualization, would we say that individuals don't develop different appraisals of related to their fears?
As far as
There,
the right. So instead of looking at the appraisal, we'd look at it more of this is just a distressful thought. Let's accept that this distress is going to happen versus trying to reappraise it.
got it. And do you ever see people still develop different appraisals, or is that something that like you don't, you're not measuring it, so you don't like see in therapy? What's your experience there?
So I do focus heavily on cognitive processing, and we think about what we call like stuck points. I should be able to control this. I should be able to, or something that gets them stuck in that faulty belief system.
Mhm.
So a part of it is identifying, well, what's that stuck point or cognitive distortion, and then challenging it with different processes, such as what's the evidence for, what's the evidence against. Are we looking at all or nothing thinking? Are we excluding important information versus looking at all information? So it's more of heavily on the process of what we're thinking and how we can change that thought versus ACT is like, well, here's the thought. Let's accept the possibility that it could be true, or let's accept the possibility that it's not. We
Mhm.
don't have to put so much value on it.
Also, it's
So,
not as much about what ends up happening. It's more about, I guess, the focus is just kind of different. It's on valued living, not whether this thought is true or not.
right. And I spend a lot of times looking at that appraisal value of the thought. And the reason why it's more distressing is because you've now seen it as a threat. And because you've seen it as a threat, your body is more heightened to it, and therefore it's going to be more repetitive. Also, with cognitive processing or the part of CBT, is more of not just the repeated, because because you tell yourself don't think about something, you're going to think about it more often, but you're valuing that as because I'm thinking about it more often, then therefore it must be true. And then we kind of get stuck in this loop all over again. So if we're able to take away that value, challenge the faulty belief, move it toward this has no value, therefore I can go ahead and move past it. So the hopes with CBT is can we eliminate some of these fears before we even get to the exposure? And so we're not having to do exposure for each and every fear. We can hopefully eliminate it just through the cognitive processing alone.
Mhm.
And that's what I like about the CBT portion of it. So we're not having to do like 100 exposures. We're down to like 40, hopefully, by the time we're done with most of them. Of course, exaggerated numbers, but you get the point.
So just
But
to be clear, you would still start with introducing CBT and assessing for the accuracy of thoughts, and then the kind of the remnant obsessions and compulsions you would target with more of an ACT, more of an ACT approach?
So it's a really good question. I've been experimenting with both ways, depending on where the client is. If I feel that there's so much anxiety around trying to prevent, then I'm going to go with ACT first. Where before I was going with CBT first. So I would do CBT, ERP, and then throw in ACT at the end. But now I'm actually seeing with some clients, if I put ACT first, then it allows the movement through CBT and ERP a lot more smoother. And so that's what we were talking about earlier, is it kind of helps with like a more natural process. So even as I'm case staffing with my associates and they're asking, well, where do you go? I'm like, I've been working this way recently. And when I say recently, I mean the past couple of months. And I like the change in the relationship even with the client too. It just feels like there's a more understanding there with ACT before just driving in and let's challenge your thoughts right away.
So how are you finding, and you're kind of experimenting with that of late, how are you finding that you make the judgment call?
So if they've had any previous therapy before at all, how long they've been diagnosed. So the ones that have been diagnosed but never had any treatment and they're older in age and was like adult, those are the ones that I tend to go with ACT first. Younger, just diagnosed, just a recent onset, then CBT is usually pretty good to start with.
Got it. Okay, thank you.
Absolutely. Okay, I love the questions. Thank you. Okay. So then the difference between the two. So cognitive intrusions have an important implication for the individual's current concerns will be given processing priority versus if the intrusion, thought, image, or impulse is perceived to be useless or irrelevant to current concerns. So that I feel like that comparison really summarizes the difference between ACT and CBT. Okay. So looking a little bit more at CBT itself, the cognitive behavioral therapy component of it. So it's looking at the importance of the thought. So it's viewed as meaningful because it reveals something important about the person. So these are kind of like the cognitive distortions that we're challenging when it comes to some of the OCD intrusive thoughts. Does it fit one of these cognitive distortions? So this thought is important because I've had it and it must mean something about me. So if I have an intrusive thought of being a pedophile, oh my gosh, then that must mean that it's true, because why would I even have that thought if it wasn't true? Personalized, well, this is my own thought. So kind of like the same thing with the importance. So then therefore it must have some particular importance to me. I must look at this thought and give it time and value. So that's a second type. Ego alien. So this is so opposite of me. Like, why would I have this thought if this is so uncharacteristic of me? Do I need to come back and reevaluate who I am as an individual or as a person because I've had this thought that I felt was so uncharacteristic? Another one is the potential consequences. This is very similar to the case study I was telling earlier. So the cognitive intrusion is viewed as having potential consequences, no matter how unlikely it is. So I know that if I close my bottle cap and put it just right, that it may not stop something horrible happening to my family member, but there's a possibility. So therefore, I must do it. I must avoid the potential consequence of not doing it, or the serious consequences too. Their intolerable degree of threat, harm, and danger. When it's that intense, it's really challenging because you'll see that level of distress in that client. So we work to like, okay, let's calm down and let's really look and reevaluate this thought and what's the evidence for, what's the evidence against, all or nothing thinking, and we really challenge that processing through. So this is the different type of common thinking errors that we see in cognitive behavioral therapy component of OCD treatment. I just thought I'd add this in here. I know it's a lot of information, but this is from a classic CBT book for OCD. So we talk about the education on the appraisal model. We go through that, that model that I had showed you earlier. Then we identify the differentiation between the appraisals that we're giving them and the intrusions. So individuals are taught to identify the primary way they misinterpret the important significance of their obsessions. So that's, again, that value component we were talking about earlier. So it is critical that the clients learn to distinguish between obsession or the intrusion itself and their cognitive reaction to the intrusion. So their appraisal of the unwanted thought. So that appraisal will give them that behavioral response of the fight or flight. So it's important that we're looking at that. It's because you're appraising it this way, this is why you're having this response. It's not because it is true or valuable. That's why you're having it. So the restructuring strategies, you've heard me say them a couple of times already. So the restructuring is, what's the evidence for? What's the evidence against? Are we all or nothing thinking? Are we including or discluding important information? Is this habit or is this fact? Really going through the cognitive processing of looking at this thought. The challenge that I've had here with cognitive behavioral therapy or the cognitive processing is a lot of times the sufferer will say, I know it's not true. I know this is irrational, but I still. And so it's good to still try to eliminate some of them just based on the question in itself. But then this is also why I feel like ACT is really good, because it's like, okay, doesn't matter what you're thinking. It's like, okay, let's rechange about how we respond to it as far as in bringing in that suffering or that displeasure. So we look at alternative appraisals. I love the ABC worksheet. Activate an event, what you're telling yourself, what's your reaction, and what are alternative ways of looking at this. It's pretty simple and it's easy to go through, and it gives you a roadmap of like which ones are more intense than others for them. The role of compulsion, ritual, neutralization, and avoidance. So this is where they recognize that their compulsion to bring down that anxiety is feeding into that faulty belief system, because now they believe they have control, and so then therefore they fall within that loop yet again. Of course, behavioral experimentation. Well, let's just see what happens if we don't do that. Let's see what happens if we challenge that on a behavioral side of it. So the aim of these experiments is to provide the client with experiences that will lead them to the abandonment of maladaptive reactions, and to the obsession and acceptance of healthier responses. Modifying metacognitive beliefs. So these are core beliefs of this about the significance and control of the unwanted thoughts, and must be addressed as part of treatment. So this is, okay, where do you feel like this belief might have stemmed from? So as we are raised, we're given like, you do well, then therefore you'll get rewarded. You do poorly, therefore you will get punished. So these are like belief systems that we're raised with. And when life doesn't quite fit that belief system, we will change the perspective of the event to fit in. So versus changing our perspective of the belief itself. So we're challenging these belief systems of where they possibly came from. And it's really important to pay attention to that. And of course, relapse prevention, just like we do with any treatment, now that we are able to get to decrease your size, decrease your compulsions, how do we go ahead and maintain that? A lot of times I like to talk about, our support groups that we have. Just, it's great. It's wonderful to come and talk to other people who understand and have similar experiences that you have. You're not at the weekly or bi-weekly necessary for individual treatment. So this once a month of keeping things at a level of awareness is pretty helpful for them. Okay, so I really like to pose this to my clients. So it's not the challenges in life that define us, but it's how we deal with those challenges define who we choose to become. You didn't choose to have OCD, you didn't choose to have anxiety, you don't choose for some life events to occur, but how you respond to them is now you're taking control of who you're wanting to be in life versus life defining that for you. Okay, so these were the books that I used as references. I know I wanted to leave a good 10, 15 minutes for questioning. So I'm open to questions.
I have a question.
Mhm.
How do you incorporate the self as context process when you're treating someone with OCD?
Okay, yes, that's a really good question. So I like to look at it as, okay, so where are you at now in life? But what were you striving to be? What goals were you working toward? So the young woman who didn't hug her mom, she's single. She's like, I want to be married. I want to have a family, and I want to, have give my mom grandchildren. So that's the person that she wants to be. That's a part of her, and she sees that as a valuable. But where she's at now is that she can't even think of a possibility of dating because what if they're dirty and I get dirty? And her responses to kissing men was kind of interesting too. She's like, oh, yuck, like dirty. And so I'm like, okay, but you're saying you want to be married. So, but that's who you are. That is truly you if we didn't have OCD. So, where are you at now? OCD is covering that up. So, what do we need to do to get there? So, and then that without judgment component of it too. I'm so mad at myself. Here I am. I wasted all this time. We accept it is what it is. We're here now. We're not here to judge, but let's put forth the actions we need to take to become the person that really you are. It's just OCD has kept you from it. It's parallel to a client. He just had his 10th session, pedophile OCD, great young man, great young individual, came in with this enormous fear after doing ERP and all this work. I told him, I was like, I felt like I met him for the first time in this last session. He was laughing, he was giving off sarcastic comments. I'm like, whoa, wait a minute, where did this come from? I was like, I feel like I'm meeting you for the first time. So that he wanted to be him again. So that was a part of his conceptualized self. Like where he was being basically suffocating from OCD. Now he's able to take that off. Now I could be me, and that's who I've been wanting to be. So it was actually pretty exciting to see that, especially the sarcasm come out from nowhere. I'm like, let me catch up.
That's so cool.
Mhm.
Thanks. Those are helpful examples to think about. It's kind of one of the
Right.
more abstract processes, so it can be harder to talk about and conceptualize in and of itself.
Yeah, it took me a lot of times going over and over that to see how this would work and then presenting it in sessions and kind of working through with some of my clients.
Yeah,
But I like it. It's a good guide.
yeah.
Okay.
Thanks.
Do you feel like sometimes in your values discussions, clients are able to articulate that that's one of their values, that they become who they are, who they want to be? Do you find that clients are able to make that leap in those early discussions?
Maybe not so much, but it does make sense as far as we look at ACT as a process from a top-down approach. We have to go through steps 1, 2, 3 before we even get to that. So I feel that if I were to pose that at the very beginning, it probably would be a hard concept to understand. But as we're working through the processes, it becomes more clear for them. That's a really good question. Thank you.
Do you have any suggestions about, like, because ACT is a process-based therapy and experiential, like how you go about introducing the processes in therapy? Like, do you do it systematically? Are you kind of introducing them as you're seeing some of the like the psychological inflexibilities pop up? Like, what's your suggestion on that part?
So how do I introduce ACT to the client?
Yeah.
So how I introduce it is more of like a psychoeducational approach. I'll say, here's this theory. It does have this process, but I feel like each component is valuable to as we work toward the gold standard of ERP. And so when I present it that way, and you feel like it's a vessel that carries you through, they seem to be interested and intrigued of, okay, well, what does this look like? Because when we talk about ERPs, in general, like, well, we're going to be having to face your fears, there's usually some kind of pushback of like, I'm ready, but I'm not ready. Like, maybe I'll come back, maybe I won't. So when you say, okay, yes, we're going to get there, but we're going to give you this tool to guide you along as we work toward it, and when we're in it, they feel appreciative of that, and I can tell that their intensity comes down a little bit. Yeah, that was a surprise finding that when I started to introduce ACT at the beginning versus the after ERPs, where I was like, okay, I'm liking this more at the beginning of treatment. Okay. Any other questions? No?
Do you have a favorite kind of go-to resource for ACT?
I actually have a couple of the books here. Let me see here. I'll grab them for you, and they're actually on my references. So Grayson, he covers ACT in a very short kind of summary, but I like it because it's like quick and to the point. And his book, Freedom from OCD, I usually recommend that book right out of the gate because of the way he talks to the reader. I feel like he really connects with them. But Everyday Mindfulness for OCD, the last one listed on the references here, that's the other one that I typically use. Now, the workbook also covers it, but in chapter 9. So that's also why, and I use that workbook pretty frequently in treatment. So that's also why I was covering ACT toward the end, because we were progressing through the workbook and it was in chapter 9. So now sometimes I'm having them skip to chapter 9 and read on that, and then we process it in session.
And the workbook is actual activities that you do with clients in session, or they have it at home and do them separate from you?
I have them do the reading and separate from me, and then we process what they have learned and what they read from it. And most of the time in session, we're also like developing their hierarchy and personalizing it to their particular one versus the examples they use in the workbook.
Thank you.
You're welcome.
Just tossing out that Katie put a couple of recommendations in the chat as well. And I actually need to read Be Mighty, apparently. I love Braided Mind by Steve Hayes and a lot of Russ Harris stuff, just to keep tossing out ideas. Have you looked at A Liberated Mind yet, Andrea? It's newer. I think it just came out. Was it last year or like the end of 2019?
I think it was 2019.
Okay.
That's technically last year. Yeah. Okay. No, definitely. I'm writing it down on my reading list to gather. Thank you so much. I appreciate that. Okay.
Well, I really appreciated this presentation. It was such a cohesive, like thoughtful overview, and really nice to kind of go back and get just this, sometimes it's a refresher, sometimes it's something said in a different way that I haven't heard before, I haven't thought of before. And there were so many moments during the presentation where I was experiencing that. So.
Thank you. I really appreciate the opportunity of being here.
Yeah, thank you so much. Well, should we, I guess, wrap up and enjoy our spring weekend?
Most definitely.
Okay. Thank you so much, and I'll see you soon.
Thank you.
All right, take care. Bye-bye.